Hello and welcome to Facebook Live with American Oncology Institute. Today we have with us one of the leading hematologists and BMT specialist in Nagpur, Dr. Shailesh Bamborde. Dr. Shailesh holds special expertise in diagnosing and treating various blood disorders and blood cancers that includes leukemia, myeloma, and lymphoma. He is also expert in management of disorders in children like thalassemia, sickle cell anemia, and bleeding disorders. Dr. Shailesh completed his MBBS from PDMC Amravati, followed by MD and DM in internal medicine, hematology, and hemato-oncology from the prestigious SGMC and KEM Mumbai. Further, he received training and fellowship in bone marrow transplantation from the renowned Tata Memorial Centre, Kolkata. Over the years, Dr. Shailesh has gained vast clinical experience and has performed over 100 autologous and allogenic transplants for various disorders of blood. And prior to joining American Oncology Institute as a consultant hematology and BMT specialist, Dr. Shailesh was associated with some of the esteemed medical colleges in our country. So, welcome to our live broadcast, Dr. Shailesh, and thank you for being on the show with us today.
Yeah, thank you. Thank you for the kind introduction. Good afternoon, everyone. In the last video, we have covered the anemia in overall as well as the management of the anemia in a overall aspect. So today we are going to discuss about the most important disease like thalassemia and sickle cell disease.
So, viewers, if you have any questions, please feel free to share in the comment section below, as Dr. Shailesh may take them up during the session. So, doctor, to begin with, we would like to understand what is thalassemia and how is it different from sickle cell anemia.
So thalassemia and sickle cell disease both are the inherited anemias. Means these are we get this anemia from our parents. We can also call it as the genetic anemias. It pass on from generation to generation. So talking about the thalassemia, in thalassemia normally red blood cell contain hemoglobin, heme and globin part. So globin, so thalassemia is a disorder of the globin chain. So normally there is a production of the 2 alpha chain and 2 beta chain which make the adult hemoglobin. So any defect or complete absence of globin chain can give rise to the will give rise to the thalassemia. So depending on the gene affected that produces the globin chain, give rise to different type of thalassemia, which I will cover later on. But in sickle cell disease, the number of the globin chains are normal, but there are mutation. So there is a normal shape of the RBC, which is a biconcave that get changed to sickle cell or just crescent line. So
Okay.
basic pathology is in the production of the globin chain.
Okay. So, what is the main cause of thalassemia, doctor?
So thalassemia, as such, I told you, it is a inherited disorder. So there are a lot of mutations happens in the gene which produces the globin chain. It is similar mutation also happen in the globin chain, which can also lead to the sickle cell disease. So in thalassemia, there are types of thalassemia like thalassemia major, thalassemia intermedia, and thalassemia minor. So they are divided depending on their severity of the symptoms, like and the pathogenesis. Like in a thalassemia major, there are normally two genes for the globin chains. If the both the genes are defected or there is a mutation, so there is a complete absence of the globin chain, and the patient will have a thalassemia major, or thalassemia can, or the patient can also have thalassemia intermedia. Only the difference is that in thalassemia intermedia, patient presented later in the life. In a thalassemia trait, which is also we called as a carrier state, which is asymptomatic, and it is due to defect in only one gene. So one gene is defective, but other gene is normal, so it compensates the effect of the defective gene. So this patient doesn't have any symptoms, and as such, this patient also doesn't know they're having a thalassemia trait or not. So in a sickle cell disease also, the globin chain which forms, there is a mutation. So normally amino acid is glutamine in the globin, which is get replaced by the valine. So there are different point mutations happens. So because of this, there is a structural abnormality, means the biconcave shape of the RBC changed to the crescent or sickle shape.
Okay, and what are the symptoms of thalassemia and sickle cell anemia, doctor? Are
So
there any
in
specific symptoms that a patient feels?
yeah. So thalassemia, mostly I told you there are three categories. So we'll talk about thalassemia major because thalassemia trait as is a carrier state and is asymptomatic. So thalassemia major, most of the time the neonates they usually presented at the 6 month of the life. Why this is because normal neonates has a two alpha and two gamma chains. They and their conversion to the adult hemoglobin that is two alpha and two beta chain happen over the 6 month of the period. But if you have a beta thalassemia, this conversion doesn't occur. So mostly this patient after 6 months of the age started having symptoms of the anemia. Their hemoglobin almost dropped to 5 to 6 gram, or sometimes it is very severe, like 4 gram. So from the 6 month of the life, if the patient is even but neonates are anemic, then one should always suspect about the thalassemia major. Then as patient grows, then patient can have a symptoms of the anemia which can be worsened. So patient can also have a jaundice in and because of the frequent blood transfusion the patient has developed the symptoms of the iron overload. The symptoms can vary from depending on the which organ involvement. It involve right from the heart, lung, liver, kidney and pancreas. So patient can develop later on diabetes mellitus. Patient also have some growth retardation problem. In a sickle cell disease, most of the patients usually presented with the bone pain. Recurrent bone pains are the most common symptoms of the sickle cell. Why this? Because normally the blood supply to the organ having a normal shaped RBC. But in a sickle, these are difficult to travel through the blood vessels. So they start blocking the blood vessels. So the blood supply to the important organ, right from the head to toe, get affected. So most commonly, it involves the bone, the vessels which supply the bone, they get clogged or get obstructed within that vessels, and because of the decrease in the blood supply to the bone, then patient started complaining of the body pain. In a 1 to 3 years of the period of in 1 to 3 years of the age, the most of the sickle cell disease patient manifest as a bone pain. I told you. Then they can have a stroke, like a weakness of hemiplegia, paraplegia. They can present it. They can also present it with the acute chest syndrome, in which the patient can have a severe chest pain, difficulty in breathing, even their oxygen saturation drops. As the kids grows up, then this manifestation again the same like recurrent bony pains. They can develop anemia also. They can also have jaundice because of a recurrent breakdown of the RBC. They can also have a gallstone. So recurrent gallstone, then another manifestation of the sickle cell disease. Then over the period of time, the most important organ in the both the disease are is the heart, because heart has to pump more and more blood because of the low hemoglobin. So over the period of time, this patient develop the symptoms of the heart failure. And in a sickle cell anemia, the patient can also develop, as I told you, the symptoms of the stroke, or they can also involve the eye. In eye, when there is decrease in the vision, in then I already told you that in chest they can have a chest pain, breathlessness. Then there is the involvement of the liver, there is the involvement of the spleen, kidney also started deteriorating over the period of time, and then you can also develop the spontaneous fracture or osteonecrosis of the bone. So these are the various clinical manifestation of the sickle cell disease we should have to picked up and we have to investigate.
Right. So, doctor, can a thalassemia patient lead a normal life?
Oh, so good question. Thalassemia, before the availability of a blood transfusion, iron chelation therapy, and transplant, the thalassemia, the survival of the thalassemia is almost up to 15 to 20 years of the age or before that, because the patient mostly used to succumb because of the complication of the thalassemia.
Right.
Now, with the advance in the treatment of the thalassemia, which as I am a transplant physician, so bone marrow transplant is the cure for the both disease, thalassemia as well as sickle cell. So with the bone marrow transplant, the patient almost get cured by 70 to 80% in both the patients, and patient can live the normal life. But
Oh,
without transplant, even only if the patient has taken a regular blood transfusion, patient is
right.
chelated adequately, if their
Hmm.
iron overload is well much controlled, still almost 50 to 60% patient can cross up to 30 years of the or 30 plus age.
You mean they can lead a normal life like a
Yeah.
childhood
In
is?
childhood, yes, only they have to be treated properly,
Okay.
so they can live the normal life. But the BMT is the only cure which can give them completely free from the symptoms as well as the disease biology.
Okay. So how is thalassemia diagnosed, doctor? Are there any specific tests?
Yes. So I always tell my colleagues, especially the doctors who are working at the rural health center, primary health center, urban health center, whenever the like right from pediatrician to the any doctor. So the mostly the pediatrician, they always get that clue that gives child. I told you neonat with after 6 months of the age, if the hemoglobin is low, so yes, then at the time we can suspect. Then recurrent body pain, also yes, we can suspect. So basic test, what we do a complete blood count with the we also see the smear. So in a complete blood count, there are three parameters: hemoglobin, white blood cell, and platelet. But in a thalassemia and a sickle cell disease, unless without some complication, this WBC and platelets are unaffected. So in this patient, the hemoglobin is very low. So next part after hemoglobin, we see the mean corpuscular volume. The MCV will be very low in this patient. Then we check the red cell distribution with. So in these three parameters, we can almost can reach to the diagnosis of the thalassemia after ruling out the iron deficiency anemia. So every iron deficiency anemia, the thalassemia has to be ruled out. Second point, then we see the smear. In the smear, we can, if the patient is sick, having sickle cell disease, so we can get the sickle cells on the peripheral smear. In case of thalassemia, we can get small size RBC. Some there are particular target cell we also get in a thalassemia. There, but the confirmatory test is the HB electrophoresis. As such, we don't do HB electrophoresis. We do HPLC, high performance liquid chromatography. This is the simple test is available in even in the simple local lab
Mhm.
that gives you the diagnosis of the thalassemia and sickle cell anemia.
Okay. And how about treatment options for thalassemia and sickle cell, doctor? Of course, BMT is one of them, but what are the other options, treatment
Yes, yes.
options?
Yeah. So thalassemia for me, like if the patient thalassemia, I always tell doctors in the periphery that we have to maintain the hemoglobin up to 9 to 10 to live the normal life. So there is a program for, and there are some guidelines for the regular blood transfusion. So we have to maintain the hemoglobin 9 to 10 by regular blood transfusion. During regular blood transfusion, we have to take care that the blood should be from the lab. It has been tested for properly by the HIV, HBCG, and TSCB. Then with the regular blood transfusion, when patient is having a iron overload, that we always check by the serum ferritin level. So we always start the chelation therapy. Chelation therapy has two oral drugs and one IV form. We usually start with the oral drug. Usually chelation therapy start after 2 years of the age. Though adequate chelation therapy, also then we monitor the chelation therapy in the form of frequently after 3 months we check the ferritin, then we check for the iron overload in the body in the form of MRI. We always do the MRI in cardiac and the liver because these two organs more mainly get involved in the iron overload. Then with the thalassemia, then we always encourage patient to take a folic acid for a lifelong just to maintain the hemoglobin production in the bone marrow. And apart from this, in a thalassemia major, we can also opt for the removal of the spleen, which actually we don't advise unless patient also has symptoms of the splenomegaly. So if the patient has huge spleen, it's causing troublesome to him, and along with that is he has a feature of a hypersplenism, like in WBC also dropping, platelet count also dropping, hemoglobin also dropping. Then yes, we can advise them a splenotomy. So in a sickle cell disease, we now always encourage the patient, means both for both thalassemia and sickle cell, whenever the patient diagnosed with this disease, we always encourage a family member to at least have a HLA testing if you have a sibling, because sibling match donor has best treatment for the transplant, and they are actually recommended. So I always encourage family members to start searching for the, they don't have a sibling because of now there is short family, so at least we
Right.
can whole the world we can search the match donor, that is called unrelated donor match, but 10 by
Mhm.
10. So I always encourage to start searching this donor. And if whenever if they are affordable, this, yes, we always offer the transplant as the first choice. In a sickle specifically, now if somehow patient is not willing for transplant or not affording for transplant, now there is a drug called the hydroxyurea. In
Mhm.
the hydroxyurea, we always start with the particular dose and we give it to maximum dose. This hydroxyurea has really make a wonder in the sickle cell life. What actually they do, this hydroxyurea works. The hydroxyurea increases the fetal hemoglobin. So fetal hemoglobin prevents the sickling formation of the sickle cell. So it has been seen in the studies that the hydroxyurea reduces the number of the painful crises, number of the hospitalization, number of the chest, I mean, almost all the most of the manifestation, and there is also improvement in the anemia in a patient with a sickle cell disease with hydroxyurea. So there are some patients to whom the hydroxyurea we cannot given because he develop a complication or he might not tolerate of the hydroxyurea because of the side effect. So there are now of oral drug which like it is actually a L-glutamine. This is a powder form. So this is also available now. It is approved by FDA in a management of the sickle cell disease with the painful crisis. Now with the advance of the science, so now we have one of the good monoclonal antibodies for the sickle cell disease, that is crizanlizumab. So this drug actually also approved for a management of the painful crisis. Little bit costly, but yes, if the patient is affording and patient is not responding to hydroxyurea, so we always give advice of the this monoclonal antibody. I always encourage a sickle cell patient to have an immunization against the pneumococcal and H influenza because these patients are more prone to infection. Mostly the
Okay.
infection happens in the chest and the CNS because their
Mhm.
spleen started functioning less day by year and year. So I always vaccinate them and the lifelong folic acid supplementation. For thalassemia trait and sickle cell disease, sickle cell trait, which are both are carrier state, we only start folic acid or because they are mostly asymptomatic and they are the carrier state. So
Mhm.
BMT is the only cure for both the disease.
Okay. So, doctor, and what is the expectancy of these patients?
I just already we discussed about the survival. So with the BMT, yes, they can live a normal life. So without BMT, yes, we have seen the patient like with the hydroxyurea in a sickle
Mhm.
cell disease, patient can almost live up to 50. Actually, as compared to the normal patients, it live less, but yes, it can also up to live up to 50, 60, 50 years almost. We have seen a patient with a sickle cell disease. And
Okay.
thalassemia, I told you with the regular transfusion and chilication, they can cross 30 years of the age.
Nice. And doctor, how does thalassemia affect pregnancy?
Yeah, very good question. This is very much important topic. I wanted to discuss in detail because see, for me, prevention is always better because you have to always prevent the having thalassemia or sickle cell child
Right.
because
Right.
every day we are getting 10,000, almost approximately 10,000 births with the sickle and thal, and there are 30 to
Right.
40 millions of the carrier. So it start the prevention at the when you detect. As I told you, the thalassemia major and the sickle cell disease, when they diagnose, we never tell them that you cannot be pregnant. Yes, they can be pregnant, but they
Mhm.
have to check the HPLC of their husband or spouse
Okay.
because if their spouse also carrying if they are carriers and
Mhm.
the patient is thalassemia major, so there are 50% chances that their child may get affected with the thalassemia major. So
Right.
even if this happen, even this happen, okay, by we didn't check or we missed the things. So within a 3 months of the pregnancy, we can always check the in utero what is the
Mhm.
status of the thalassemia by coronary
Okay.
pillar sampling. So we can take the sample, we can send, we can see if it's they found that it's a thalassemia major in a bachu. So this we give always option to the patient, or you want
Mhm.
to carry with this or you want to abort. So that choice has to be to the patient.
Right.
Second, we always encourage patient to have another mode of the pregnancy. Even if then the patient wants to continue the pregnancy, so we have already tell them in a thalassemia, pregnancy can be normal Only that you have to maintain hemoglobin up to 9 to 10. Her cardiac function should be good, because in pregnancy, everything overload is on the cardiac. If the cardiac function is good, she is well having maintaining hemoglobin 10, so she can have a normal baby.
Okay.
And all I told you before that, we have to cross check. We have to check the thalassemia or sickle cell status of the husband. We same with the sickle cell disease. Only thing in sickle cell disease, there may be chances of getting a painful crisis, because the pregnancy itself is a stress. So any stress, any dehydration, any fever can cause a painful crisis in the sickle. So in a pregnant patient, we always try to maintain the adequate hydration, adequate analgesia, and with the and maintaining the hemoglobin up to 10, so she can also have a normal baby. But they are more prone to develop intrauterine growth retardation, fetal abnormalities, because of the chronic anemia. So, but still they can have a normal baby.
So, what is the best diet for thalassemia patients, doctor?
Pardon me?
What is the best diet for thalassemia patients?
Diet. Okay, good question. So diet, I always tell that ki, sir, I am the carrier of thalassemia trait. So should I
Mhm.
take a iron tablet or not? Or
Right.
should I take a iron containing food or not?
Uh-huh.
So I always tell them that ki thalassemia trait is a carrier state. Unless you have a proven iron deficiency, do not take a iron tablet. Or but yeah, you
Right.
can have a iron containing food, because in a thalassemia trait there is no risk of a iron overload. Same with the sickle cell trait. We always, unless they have iron deficiency anemia, we don't given them an iron supplement. But yes, they can have a normal food. But in thalassemia major, they are higher at a higher chances of iron overload. So again, the same principle apply to this patient also. Unless they don't have proven iron deficiency, we don't give iron supplement to them, and we tell them to completely avoid the food containing iron. Same with the sickle cell disease. Those requiring blood transfusion, they are also at high risk of developing iron overload. So we go with the same protocol for the thalassemia. But for the thalassemia trait and the sickle cell trait, carrier trait, yes, you can have your normal diet.
Okay. And doctor, how has COVID-19 affected individuals with
Yeah.
thalassemia?
So I wanted to. I think COVID-19 has the same protocol. Like you have to follow the same protocol. You have to wear a mask. You have to keep frequent hand washing. Thalassemia, as such, this is not an immunocompromised state. But in sickle, yes, sickle patients
Right.
are immunosuppressed, because I already told you the spleen is not functioning well, so they can prone to infection in the chest and brain. So it's sometimes very difficult for a sickle cell patient with the COVID to
Mhm.
differentiate whether the pneumonia due to COVID or because of the sickle. So
Right.
this can be challenging, but yes, we can manage this patient. The only thing that in a sickle, I always advise, if the patient is a sickle, we should be isolated in the home. He should have a separate room. He should follow all the COVID-19 guidelines. Means I always tell them not to get affected by the COVID-19. Even if they get affected with the COVID-19, yes, the management will be the same.
It's
There will be no
manageable.
difference in the management. But only the risk is more in a sickle as compared to thalassemia.
Right. So, doctor, can thalassemia and sickle cell be prevented?
Yeah, it's prevented. I already discussed this about the prevention. The
Those
prevention
tests.
start
Yeah.
right at from the rural health center to the urban health center. So
Right.
there are so many screening tests available, right? We in the neonat also we do the screening test. With the screening test, yes, we can detect the
And
sickle.
how are these screening tests priced, doctor? Are they very expensive?
No, these are not expensive, because the national we have program.
Mm-hmm.
The government
Okay.
has a program for that, so they are very cheap at a cheap cost. Even the HPLC is very cheap. It
Okay.
available at a local lab. And what I'm telling you one thing, this lab, the machine which they have same machine everywhere in there. So if the report, most of the time, 99% the reports are the same. So every local lab nowadays has HPLC. So yes, so I always encourage that if you found to have a carrier, if you want to get married, just check the HPLC of the spouse, if,
Mm-hmm.
and then you take a decision. You can, yes, you
Right.
can marry, but you should know the consequences of that. If you are both are the carrier state, like
Mm-hmm.
husband and wife both are carrier, so there are 25% chance that their child can have a major disease.
Major.
then
Right.
50% can be carrier. So with
So,
this background information, that is called as, we always do a premarital counseling, and we always, and another is marital counseling. So this counseling has to be done, so they may be
right.
more aware, and we can avoid. Means our, as a hematologist, my aim is to prevent the birth of the thalassemia and sickle.
Right. So before we conclude, would you like to add anything, doctor?
So, for everyone, I just wanted to tell you that whenever there is anemia, mostly suggestive of iron deficiency anemia, always rule out the thalassemia in this patient. Second, in a sickle cell, I have seen the patient even up to 20 years of the age, yet not diagnosed with the sickle cell. Because the
Mhm.
presentation is right like a bony pain, the patient goes to
Right.
orthopedic. So whenever I have a recurrent, like, clinical history, always give you us some judgment and some give direction to the diagnosis. If you have a good clinical history, then we can almost conclude, and with the help of the CBC, simple test CBC. In the CBC, you have to see a hemoglobin, MCB, you have to see the smear, and once, so this clinical history with the hemoglobin and then HPLC, yes, we have diagnosis.
Right. So, with that, we conclude our today's discussion. Thank you so much, Dr. Shailesh, for such an insightful session. Viewers, in case you have any further queries or if you wish to seek an appointment with Dr. Shailesh, please contact on the number scrolling below. And if you have liked this video, please share it with your friends and follow us on our Facebook page. Until we meet next, stay healthy and stay safe.
Thank you. Take care.
Thank you.